Well, hello everybody, and thanks for attending the session. We're going to be talking about living on borrowed time, a call to action for severe aortic stenosis patients. And I want to do some brief introductions first before getting into some questions for you all. So I'll introduce myself first. My name is Sri Kavimulapalli. I'm a non-invasive cardiologist and medical director of the Echo Lab at Duke University. And immediately to my left is Jordy Strom, who is also medical director of the Echo Lab, but at Beth of Israel Deaconess in Boston. And immediately to his left is Dr. Andre Pop, who's an interventionalist at Ascension, Illinois. And so you'll be hearing from all three of us and hopefully all of you through the course of the session today. Without further ado, I'll reintroduce Jordy Strom, who's going to talk a little bit about why are only half of the patients who are diagnosed with severe AS being treated. Jordy.
Thank you so much, Streak, and thank you everybody for having me here. I think this is a really important topic, and it's clear, I think, for some of the sort of early questioning here that I think there are lots of different ways in which people practice care, but I think as we will show you, there's some reasons to refer early and often, I think, to care, in part because these patients are high risk and high severity. These are my disclosures. So my job today is to really take you through the overall prevalence estimates of AS and really see, for those of you who are seeing AS on a daily basis, this is the 10,000 foot view. We know that an estimated 16.1 million adults over age 60 are estimated to have aortic stenosis, and that number is just projected to double by 2050 with the growth in age of the overall population. At the same time, many cases of that AS are symptomatic and severe. About 1.3 to 1.6 million Americans who are over age 65 who have severe symptomatic aortic stenosis. So this is a very common problem. And if you think about it as uniquely or in its own sort of right, you may not necessarily think about it sort of correlates in other specific diseases. And I wanted to sort of compare aortic stenosis here to several of the things that we're used to treating that we know have really poor prognoses. This is on the left, the risk of high risk severe aortic stenosis versus metastatic cancer. And you can see that it's very similar to the mortality of lung cancer and many other types of cancer or dementia. And on the right, this is from data that we have where we looked at severe aortic stenosis and aortic stenosis really across the risk spectrum compared to other such diseases. And as you can see, dementia and cancer have very similar risk ratios. And so really, if you conceptualize it in this sense, we would be very aggressive about a patient who comes in and has cancer. So should we do anything else other than that for a patient with severe symptomatic aortic stenosis? And I would argue the answer is probably not. So this is also just in cases it's just thinking about mortality. Of course, we have a massive impact on the economy and economies at scale. This is an article that we published recently that looks at the burden, the health burden in years of life lost by severity of aortic stenosis. And if you sum it all up, the take-home point is it's about 5 to 7 years of life lost from having aortic stenosis, period. And that translates into costs of over $400 million for men and over $467 million for women. And as the disease progresses from mild to moderate to severe, you have increasing degrees of cardiac damage. Those cardiac stages of cardiac damage in and of themselves mean that those patients have greater complications after their procedures and are more likely to have higher costs. And so when you look at stage of cardiac damage in the lower right-hand corner here, you can see that as the stage of cardiac damage increases at the time of aortic valve replacement, the costs of taking care of them after that procedure go up and up and up. And so more important to intervene early and often. But of course, we know that not everybody gets aortic valve replacement, and there are obstacles really along the line of the continuum of care, based from progression of the disease to diagnosis to referral to ultimately treatment and then post-treatment recovery. So, for example, we know that even though the proportion of patients with each severity of aortic stenosis is similar across racial and ethnic groups, we find that 1 in 6 white patients and 1 in 3 Black patients have severe AS that's undiagnosed. Building upon that, even if you look at those who are diagnosed, the 1-year rates of diagnosis uh, uh, are much lower for those who are blacks and Asians, and only 1 in 3 patients are diagnosed within 1 year of the echo. That's a sobering statistic, and it's particularly bad for Black and Hispanic patients. And that's been shown across the board. And here on the right hand graph, you can see the national population trends in treatment for aortic stenosis. And while whites here in the red, and I'm going to pull up the arrow here, you can see overall, had the rates of AVR have been increasing. They're increasing. The baseline rate of AVR is much higher than that for Blacks, Asians, and Hispanics. And the rate of increase over time is much faster for whites compared to Blacks, Hispanics, and other and Asians as well. So we know that there are some disparities involved in care. These are overall disparities that are similar to other types of areas of care where we encounter them. And they occur not just at some other medical center across the street, but they happen at your medical center as well. And so this is an example of this really prominent paper that was published by Samuel Maria and his group in Jack a couple years ago, looking at those individuals with Mass General Hospital. This is one of the world's greatest academic teaching hospitals, looking at those who met class 1 indications for aortic valve replacement and those who actually got treatment. And you can see in the top left here, those who had indications, class 1 indications for high gradient normal ejection fraction aortic stenosis, only about a third of them did not get aortic valve replacement. And if you look at those who had a low ejection fraction, that number goes up to about 47%. That's on the people who had high gradients. What about the people with low gradients? Well, there the treatment rate is even worse. So 2/3 of all patients with low gradient normal ejection fraction and over 2/3 of those with low gradient low ejection fraction had no treatment whatsoever and no aortic valve replacement following this. And this is at a very good center. And overall, with severe symptomatic aortic stenosis, we know that the treatment rate is under 50%. And really, treatment is indicated for all of these individuals. What's more, we know that aortic valve replacement saves lives. So this is the exact same study looking at those who received aortic valve replacement versus those who didn't receive an aortic valve replacement. And it doesn't matter how you cut the statistics here, every single group benefited, and every single group benefited substantially from an aortic valve replacement. So this is a life-saving intervention, and that really hasn't changed dramatically insofar as we know that we've known for quite some time that aortic valve replacement has been life-saving, and now we have better treatments. So if you look back in 1982, when historical operative mortality for an aortic valve replacement was 15%, we were having a much different conversation about the risk-benefit calculus and favoring watchful waiting of those individuals. But we know now, of course, that current operative or procedural mortality in the partner trials was 1% with TAVR. So that really changes things dramatically in terms of the risk benefit of waiting and the risk benefit of acting right away for these individual patients. So, and building on that, this is, of course, a really wonderful graph, and one that I think is known to many of us. We've learned it in medical school. We've learned it along the way in training, et cetera. And this comes from really seminal work that Braunwald and Ross did in 1968, looking at the sort of the valvular heart disease over time and showing that once you develop the onset of severe symptoms, the average age of death is between 2 to 5 years after the onset of symptoms, but that there was a long latent period beforehand. And I want to always give throw a little bit of caution into this. And when I talk about this with our fellows, I ask them to look at the average age of death. You can see the average age of death is a little over 60. That's a pretty young population for overall aortic stenosis population. And that's because the average age of subjects in this study was 48 years old at the time of clinical presentation. In fact, this was a 64 patient study. It included a mix of bicuspid, rheumatic, and calcific aortic stenosis. So it was a hodgepodge of group, and it was incredible at the time. It was one of the first uses of catheter diagnosis of aortic stenosis to really follow the trajectory of aortic stenosis history. But it really predated the widespread use of echo in our community. And so we still come back to this graph quite often, but I would suffice to say that we're in a really different paradigm now than we were in 1968. And so we really need to recognize that insofar as our treatment and our referral patterns. And this is from recent data that have suggested that nearly 40% of patients who present with advanced signs or symptoms, having already tipped over the scale into having severe symptomatic aortic stenosis. And we know that that symptom onset can be really rapid and really unpredictable. In this particular study, they watched people over time, and 1 of 4 patients became symptomatic within 6 months. And by the end of about 4 years, 90% of patients were symptomatic and had and required treatment. Almost 50% of patients became symptomatic within 1 year. And this can happen. This isn't a slow and steady progression where people gradually feel more and more short of breath. This is often an acute event, an illness or otherwise, that tips people into having severe symptomatic aortic stenosis, and it can be fairly unpredictable. So having these people already seen in care early is often a helpful strategy so that you can act on their severe symptomatic aortic stenosis as soon as it occurs. But of course, what do we know? We know that general cardiologists as a group have massive differences in terms of their referral rates for aortic valve replacement. If you just look at the rate of referral across cardiologists, there's a 2.3-fold difference in receiving AVR if the patient was just simply had a different cardiologist. And so think about that for a second. The standard of care that we're giving to our patients is massively different if they're coming to one clinic or your clinic versus another clinic. And so building upon that even further, the mortality is actually lowest amongst those physicians who refer the most. It's about 45% lower, in fact, with the general cardiologist management, and about 22% higher amongst cardiologists who refer the least. And so this is the actionable step. You can make a massive difference in these patients' care by getting them into care, getting them referred for further clarification of the diagnosis if that's needed, or treatment if necessary. And so this is really where things stand, and this is the reason that Edwards is partnered with the American Heart Association across the Target Aortic Stenosis Initiative to really implement a quality metric of getting people into care within 90 days of their first echo diagnosing them as of having severe aortic stenosis. And so this is really where this referral pathway comes into play, and it involves both the patients being aware, the healthcare providers being aware, and the integration of teams to be able to marshal people along in care so that they don't wait. We know, in fact, that the rate of mortality while waiting for AVR is about 2% increased. There's a 2% relative increase in mortality per week in waiting. So waiting on the list to get a TAVR is not benign by any stretch of the imagination. And if we can reduce that time to get people into care, that's going to have benefits to our patients as a whole. And that's been recognized through this initiative, which I encourage you all to participate as part of. So, in response to Dr. Amalia's paper a couple years ago, this was a really wonderful editorial that was written by Angela Lowenstern and Brian Lindman, calling for really systems changes in the treatment of aortic stenosis. We know that patients are likely to benefit, and patients with severe symptomatic aortic stenosis are likely to desire aortic valve replacement and be treated by aortic valve replacement in a timely fashion without complications if we can get them into care. But getting them into care is really critical. And so we know that in one of the nation's leading healthcare systems, there's evidence of an overwhelming reduction in the risk of death with AVR in all AS subgroups evaluated, but less than 50% of those with AS with an indication or potential indication for AVR were treated. And so we are far off from where we need to be, but we're hoping to create a pipeline to get us closer. And that's integrating excellence in both the procedure itself, but also the process of getting the patient referred and evaluated for that procedure. Unless you think this is just an issue in one population, these are recent data that were just presented at TCT this last a month ago, looking at real world evidence in a large community-based healthcare system. This is, I believe, over 50 different healthcare 50 different hospitals, looking at those with a class 1 indication for aortic valve replacement who received treatment. And only 25% of patients with a class 1 indication, high gradient, severe symptomatic aortic stenosis, received treatment within 90 days. So we've got a long way to go to meet that metric. And now about 58% of those with high grade and severe aortic stenosis who had a class 1 AVR indication didn't receive treatment at all. And so, how do we create the urgency around this area and create urgency both for the providers, but also for the patients in getting their aortic valve disease treated? And one of the ways in which we can really assess that is a terminology and how we use this and how we phrase this with patients. It turns out that if you call it aortic stenosis, patients are less likely to see it as a severe disease than if you call it heart valve failure. If we think about heart failure and the kind of connotations that has for patients, heart valve failure puts that into a similar box of where it is in line with cancer or stroke or other things that patients really readily recognize have significant implications. So in this particular case, we ask patients, how would you rate the diagnosis of the following as being extremely serious? Um, of course, heart valve failure pops to the top of the list here. How long would you wait to schedule a patient a follow-up visit after diagnosis? Again, heart valve failure popping to the top of the list. How would most people rank the seriousness of the underlying disease? Heart valve failure is at the top of the list. So we have to change the way that we communicate both with our patients and with each other to be able to make sure that we can get patients into care in a timely and effective fashion so that they can be treated accordingly. Thank you very much.
Thanks, Jordy. We're going to go into a little bit and spend a few minutes on challenges in the actual diagnosis of severe AS. So I think key points based on the guidelines as they exist. We clearly need to assess symptoms: exertional dyspnea, decreased exercise tolerance, heart failure, angina, syncope. And then, of course, we need to understand the severity of the aortic stenosis. Well, we might think out of those two things that the symptoms are the simple part, but they really aren't. So there are differences in how men and women present with symptoms of severe AS. Men tend to have more angina, more atherosclerotic burden, smokers. Women, more on the dyspnea on exertion side of things. They tend to be frail, older, perhaps higher STS scores. And then I think a couple of points which will become very important in a few minutes. They tend to have smaller LV outflow tracts and to have discordance between the various echometrics of severity of disease, and therefore they tend to have a greater prevalence of low flow, low gradient severe AS. So again, back to these symptoms, we think we all know how to assess symptoms, right? Well, this is actually quite an old study from Guy's Hospital in England. And what they did was they took patients who were supposedly asymptomatic, according to the clinicians, had severe AS with valve areas under 0.8 centimeters squared, and then put them on a treadmill. And it turned out that 28% of those patients, once you put them on the treadmill, they actually had symptoms on the treadmill. And symptoms on the treadmill were the number one predictor of whether they would develop symptoms in their daily life later on. You can see that there, the odds ratio is between 7 and 8, depending on whether it's univariate or multivariate. So what might the best practices be for determining symptoms? You really need to probe for physical activity level, exercise intolerance, and you need to ask a family member. I think many of us have had this experience with a patient where the patient says, "I'm fine," and the family member is going, no, they're not fine, right? We actually heard at the Target AS event yesterday, a cardiac surgeon saying he didn't think he had symptoms until he couldn't walk and talk at the same time. Okay, you really need to push for this. Consider exercise testing. I think this group has already demonstrated from the questions that you will use exercise testing, but remember, it's a two-way indication. You can exercise test patients who are asymptomatic severe AS, and you should do that cautiously, but you should do it. And again, if this is starting to get a little bit more complex than you can or want to handle, you have help. Consider sending that patient to your heart team. All right, so we talked about symptoms. What about the severity part of it? Well, if we thought symptoms was complicated, severity is going to get a little bit more complicated. So we really need to understand what's the definition of severe AS. We need to understand, are we in a quality way assessing all the things that are necessary and identifying patients, and then are we reporting it in a quality way? So we're going to spend just a minute going over this complexity. So how do we know if someone has severe AS? We need to measure the mean gradient. We need to measure the peak velocity. We need to calculate the aortic valve area, which means we need to measure the LVOT diameter. We need to report the dimensionless index, which is given here. It's a ratio of velocities. And as you see, even that may not be enough. So in the patients who have concordance, meaning they've got a high gradient and a low aortic valve area, this is relatively simple. They've got severe AS. Hopefully we know what to do, although Jordy has shown us that we don't always do the right thing. But what about in those patients who have discordance? They've got a low aortic valve area, but their gradient is not quite high enough. You need to take the next step, the stroke volume index. You need to calculate that. And once you've done that, putting together the stroke volume index, the ejection fraction, you can decide, does this patient have classic low flow, low gradient AS? Do they have paradoxical low flow, low gradient AS or normal flow, low gradient AS? Okay, that was a mouthful, all of that, right? But the point here is that these patients need more testing. Look at the bottom of the figure. They're all supposed to get either dobutamine stress echoes or non-contrast aortic valve calcium scores. So again, if this is sounding confusing or sounding like it's a little too much, you have help, but your job is not over with a mean gradient and an EF. There is much more to this, and we owe it to our patients to do this correctly. Now, here's some, I think, sobering data that we're presented here at AHA during this meeting. This is in a very large collection of institutions, 30 institutions, over 2 million, you can see almost through 3 million echo reports. This is the percentage of time that these various metrics are being reported. AVA, so missing 35% of the time. Mean gradient, missing 30% of the time. Vmax, 25% of the time. Stroke volume index, missing 85% of the time. LVEF, missing sometimes. AS diagnosis, not even listed 36% of the time, okay? So we need to pay attention to what we're doing here. We're not doing it very well. And then I would even point out, so when there is discordance, the thing to look at here is when there's discordance, it's confusing. What is it that we should be calling these patients in terms of severity? Well, this is a subgroup of the last slide I showed you. It's about 1.2 million patients. When there's discordance, but the patient had at least one metric consistent with severe AS, 52% of the time we called that severe, 28% of the time we called that moderate, and 20% of the time we called it less than moderate. These patients had a marker of severe AS and we called it less than moderate. So 1 out of every 2 patients were misdiagnosing. Sometimes 1 out of every 5 patients were calling it mild or less. All right, the way to look at this graph is similarly. So again, if you had any of the 3 parameters, at least one of the 3 parameters that might be consistent with severe AS, mean gradient, valve area, peak velocity, look over all the way at the right. The severe patients, 36% of them had all 3 of those parameters, 15% had 2 of the 3, 33% had 1 of the 3. Look at what we call moderate to severe. What is moderate to severe? It's we don't know the answer. 59% of them had 1 of the 3 parameters consistent with severe AS, okay? So we're hedging, and this is a problem. Clinicians don't know what to do with this when we hedge like this. So if we had to summarize what I've been going through, symptoms are really important. You really need to probe for those symptoms. Don't be afraid to use a stress test. We need to actually record the parameters that are necessary to make the diagnosis. LVEF, stroke volume index, mean gradient, peak velocity, AVA. And then when there's discordance, we need to do additional testing. Dobutamine stress echo, calcium scoring of the aortic valve is in the guidelines, and some people might do a cardiac catheterization. But again, this is complex and it's difficult. Don't forget, you have a phone a friend. You can always refer to the heart team. And this matters. Jordy already showed you these graphs in a previous slide, but essentially when we treat each of these subgroups of patients, whether they have a normal gradient or a low gradient, they do much better when we treat them, and they die when we do not treat them. This stuff matters. Dr. Pop.
Hi, I'm Andre Pop. I'm an interventional cardiologist. These are my disclosures. So you did the right thing. You identified the patient as having severe symptomatic aortic stenosis, or you just don't know and you want to get help, and you send them to the valve team. So I've been saying for many years, I think the valve team is the biggest benefit that came out of the TAVR. Basically, before TAVR existed, we didn't have valve teams. We now have valve teams. we have for the first time, we have physicians, cardiologists, and surgeons and anesthesiologists sitting together and really discussing patients. And that's something very unique, and that's something that is tremendously valuable. We also know that valve teams change outcomes. Hospitals that have surgical programs but don't do TAVR don't have as good outcomes as surgical programs that also do TAVR. And I think we're at a point right now where regardless of whether the patient will be getting TAVR or SAVR, they need to get a CTA and they need to be seen by the valve team because that will get them the best outcome. We've been working as a society and as a specialty to reduce the time it takes from diagnosis to treatment. And we're doing that by educating the referring physicians, by, in some places, automatic referrals. So you have a diagnosis of aortic stenosis on echo, you get a referral to the valve team. We're streamlining the valve team workup, the clinic workup. We're facilitating access to the clinic. We're facilitating information transfer between the referring physicians and the valve team. We're expediting the workup in clinic, and we're trying to expedite the time from the moment that we see the patient in clinic to the moment we're getting them treatment. And overall, we're trying to limit the treatment backlog. If you have a 6 months backlog, then you're looking at probably 10% of your patients or more who will be dead waiting for treatment. So you cannot have that long of a backlog. This is how we do it. We basically, the moment we have a diagnosis and a referral, we get the patients in clinic. We have dedicated CT spots on the morning of clinic. Valve conference happens once a week, but generally in 90% of the time, we know what the treatment is going to be from the clinic. And then we try to get people to treatment within a week, if not less than that. Once they get treated, they spend 6 to 24 hours in the hospital, they go home. The next day they have a follow-up with the valve clinic coordinator, which is virtual, and then they follow up at 30 days per registry requirements. At the valve clinic, patient shows up, they get their CT, they see two physicians, the interventional cardiologist and the CT surgeon see them separately, but sequentially. They get a 5-minute walk test, they get the other mandatory assessments for the registries, they get a lot of education, and they get, very importantly, a setting of expectations. Because if the family expects the patient to spend a week in the hospital and you tell them the day of procedure they're going to go home after 8 hours or 24 hours, they're not going to go. They're not going to be happy. So you have to set expectations from the moment you see them in clinic. We encourage our general cardiologists to do all the workup that they can do. They can do an echo, they can do a cath, they can do an EKG. When the patients come to clinic, we're going to do a CTA, we're going to repeat the echo if it's necessary, and we're going to do an EKG if we don't have a recent EKG. Some patients we're going to refer for dental evaluation, but even that is very selective. We certainly are not going to do before TAVR urinalysis. We're not going to do PFTs routinely. We're not going to do carotids routinely. We're not going to do anesthesia evaluation in clinic routinely. These people get the workup they need, and there's good evidence that all this testing ahead of time makes absolutely no difference. So once the patient gets their AVR, we encourage enhanced recovery. So we get these patients out of bed at 4 hours. They start walking at 4 hours. We recently had a very nice Hispanic patient who actually danced out of bed at 4 hours. And we encourage early discharge. As much as families may be nervous about early discharge, some people are actually very happy about early discharge because when grandma is 85 and has a history of sundowning, the last place you want them to be is in the hospital. We also reduce the potential for deconditioning, nosocomial infections, all those kind of things. We talked about a virtual visit at 24 hours. We encourage these patients to have quick follow-up with their referring cardiologist, especially if they come from a long distance away. We get everybody enrolled in cardiac rehab, and if they have heart failure, we get them enrolled in the heart failure clinic, and that keeps them out of the hospital. So in the hospital, once you've done the TAVR, the workup is also very minimal. They get an EKG on arrival from the cath lab. They get an EKG at 6 hours. They get a very limited echo. You don't need a full echo. They get a CBC and a BMP if they're still in the hospital the next morning. And we don't routinely get physical therapy evaluation because if you walked in the hospital, you should be able to walk out of the hospital. Um, we know that the long-term outcomes of TAVR are equivalent to those of surgery, and the rates of reintervention are very low. On the left side, you have data from the NOTION trial. On the right side, you have data showing that the rate of reintervention are extremely low, even going out to 10 years. We know that the pivotal studies have shown that TAVR is efficient and is durable. On the left side, you have the combined endpoint in partner 3. On the right side, you have the survival endpoint, and they are very favorable at 5 years. And we know that with the latest iteration of the SAPIEN S3 Ultra valve, the outcomes are really exceptional. All-cause death, 1.4%, cardiac death, 0.8%, stroke, 1.7%, etc. And these are mean lengths of stay of 24 hours and 94% of the patients going home. Now, TAVR has been expanded to include a wide variety of patients, ages, comorbidities. I'll give you a few examples. This is a patient that we saw recently, 62-year-old man, bicuspid aortic valve, history of stroke, history of CLL, good EF, clean coronaries on cath, pretty calcified valve. He was treated July 10th of this year. He came in the room 5 minutes before 2 o'clock. We started the procedure 25 minutes later. We were done with the procedure within half an hour, and the patient was back in the holding area less than an hour from the moment the procedure started. He was discharged the next morning at 7 a.m., and at 1 month we saw him in clinic and he was doing great. This is what we aim for every single patient. This is our standard. This is one of my favorite patients that I actually took to Irvine to meet the team that made her valve. She's 95. I've known her since age 91 when she had moderate to severe. We shouldn't be using that, but basically borderline severe aortic stenosis and no symptoms. We basically sat on her for 4 years because she had no symptoms. We got her through 2 surgeries. The moment she became symptomatic, we treated her within a couple of weeks, and she's just turned 96 and she's doing great. And she told me, and I quote, "Dr. Pop, if I had stayed out of trouble, I would have died at age 40 of boredom." So I guess that's what it takes to live to age 96 and get TAVR at age 95. Thank you.
We have a couple minutes for questions, and I would encourage anyone in the audience to either come up to a microphone or you can use your app to submit questions. And while we're waiting for people, yeah, go ahead, sir.
If a patient's ascending aorta is dilated also with severe aortic stenosis, which many times you see, say it's 4.8, 4.7, even 4.6. So the question about surgery versus TAVR, how do you decide?
Andre, do you want to take that?
Okay, so that's a great question. I think it depends very much on the age of the patient. There was actually a great editorial from a cardiac surgeon that commented on a patient with kind of like that, 4.85, maybe even. And their argument was that if you're putting in a TAVR valve that allows you to easily explant in the future, and it allows for easy redo TAVR, then you can make an argument that you can start with a TAVR valve, and if in the future the aorta grows, then you're going into a virgin chest and you can do a simple surgery. Whereas if you go in, you don't replace the aorta because the guidelines don't indicate it. You put a surgical valve, and then in a few years the ascending aorta grows, then you have to come back and go into a chest that's already been operated, and the risk is going to be higher. But that is something that there's no standardization on yet. And I think that's where the valve team really shines. bringing together the surgeon with the cardiologist to come to a conclusion in each individual case.
Yeah, Andre, I wanted to follow that. I mean, you gave the example of the 90-some-year-old patient that you waited and waited and waited, and then you just gave the example of the depth of discussion that's happening in the valve team. You're very busy. You know, one of the myths maybe that I hear is that there isn't time to see the patients where we're not sure what to do or we're not sure whether they need therapy just yet. Can you tell me how you handle that in your system?
So I think that, we take a lot of time with the patients in the valve clinic, certainly a lot more than the 15 minutes that are allocated with a double book every hour in my regular clinic. And we go through everything in detail and we talk to them about symptoms, we talk to their family. Generally, when people come to valve clinic, they bring multiple family members, which, as you said, helps us tremendously. And, we're not in a hurry to treat these patients. If there's no reason to treat them, we'll be happy to sit on them and watch them very closely. But sometimes we start their workup, because if you are borderline, if you're entering severe, you can get a CT scan right now. And next time that you come to the hospital, if something dramatic has happened, if you've been lost to follow up, and now all of a sudden you have severe or critical aortic stenosis, I can turn on a dime and treat you. But really, a referral to the valve clinic is not a referral for treatment. It's a referral for consideration of future therapies.
Thank you. Other questions? Yes, go ahead.
Can you hear me? Yep. This was great. There are certain patients who come with symptoms, and then they are found to have severe AS. They're admitted. The heart valve team is consulted, and then how does one decide that certain patients they need the AVR right away during their inpatient stay versus you send them out, bring them back ASAP to the heart valve clinic? How do you figure out that gray area of decision making?
So it's not an easy decision. I would say that if you've had syncope, in my mind, you're getting a valve. If you come in with heart failure, and especially if you've been in the hospital for 2 weeks with heart failure and you're sick as a dog and you've been exposed to all the bed bugs that we have in the hospital, uh, I may be tempted to do a balloon valvuloplasty, get you to inpatient cardiac rehab, get you nice and strong, and then as soon as you come out of cardiac rehab, I'll get you a valve. But I have a patient right now in the hospital who, to your exact point, she was seen by a general cardiologist a year ago. She said, I don't want anything done. And now she's admitted in florid heart failure, and all of a sudden she wants everything done. So I had to do a CAT scan on Friday, and I'm going to give her a valve on Monday because she has no family member, she has no support. I don't feel comfortable sending her. But for the majority of patients, unless they have AI or unless they're otherwise perfect, I prefer to buy some time to get them away from the acute episode of care and bring them back. And the best outcomes with TAVR are generally when you come to the hospital in the morning and you go home the next day. Once you've been in the hospital for 3 weeks, the outcomes are not as good.
I wanted to maybe finish with one question for you, Jordy. We talked a little bit about this moderate and severe thing. Tell me, how do you, when you're reading on your own, and as you think about being a medical director of an echo lab, what are your thoughts about grading moderate, severe, and what do you do about that?
Yeah, it's a really an excellent point. I think you've heard from a number of us that this term moderate to severe aortic stenosis sort of gets thrown around and it often gets included in a lot of echo reports, and we really discourage the use of that term. If you're hedging and you're not sure if it's moderate or severe aortic stenosis, that patient is severe enough to be referred to a heart valve clinic to get that full determination. And sometimes you can't make that determination up front. You may need additional testing. So if it's probably on the border of moderate to severe, it's probably severe, or at the very least, that patient should be treated accordingly. One of the things that we do in our lab is we actually also use the patient's body surface area. So we have a predicted LVOT diameter. We know that one of the most critical sources of error in the echo is measuring the LVOT diameter correctly. So we actually predict somebody's LVO2 diameter based on their body surface area. And we have our sonographers look at this, we have our physicians look at that. And if it's greater than 2 millimeters off from what's predicted, then we suspect that there may be mismeasurement and going back to sort of making those determinations. But it can be challenging. And I think that's the role of the heart valve team in trying to help make those decisions as well.
I wanted to thank everybody. We're at time. We're all happy to answer questions further, but I want to thank everyone for your attention, and hopefully you've all gotten something out of this. Thank you.